Afternoon and welcome to the Translational Applications in Public Health lecture, a collaboration between the Institute for Public Health and Medicine, IPHAM, and the Northwestern University Clinical and Translational Sciences, NUCATS, Institute. I'm Tara Lagu. I'm the Director for the Center for Health Services and Outcomes Research in IPHAM and a Professor of Medicine and a hospitalist at NM as well. I want to thank you for joining us today. First, just a couple of business items. Please use the Q&A function in your Zoom menu rather than the chat to submit questions. We will be following the Q&A function and we will have some time at the end of the presentation for Q&A. Today's presenter is Dr. Daniela Ladner. Dr. Ladner is a professor of surgery and medical social sciences, the associate surgical director for liver transplant and hepatobiliary surgery, the founding director of the Northwestern University Transplant Outcomes Research Collaborative, NUTORC, and a principal investigator for 5 large NIH grants, including 2 training grants and 3 large research grants, totaling almost $4 million in direct funding per year. However, beyond her titles and incredible funding profile, she really has been a leader and trailblazer at this institution, nationally and internationally, and has been dedicated to creating academic pathways for junior faculty and trainees with a focus on underrepresented groups, has been a beloved mentor of medical students and trainees, and has really blazed a new trail in her work in cirrhosis and transplant, and really is one of the best examples of successful transdisciplinary science at the Feinberg School of Medicine. So I'm so grateful to have the opportunity to present to you Dr. Daniela Ladner, presenting Cirrhosis, an Unappreciated Public Health Challenge. Welcome, Dr. Ladner. Thanks so much.
Thank you very much, Dr. Lagu, for the kind introduction. I'm going to talk to you today about something I'm pretty passionate about, cirrhosis, which I believe is an underappreciated public health challenge. I will talk about a bunch of different areas, and these are just some funding sources that led to the results, or some of the results I will be presenting. So in brief, I'm going to go a little bit over the history, anatomy, and physiology of the liver. We'll go over function of, we'll go over cirrhosis, portal hypertension, mortality prediction, disparity, commonly known and less known risks of cirrhosis, some resource utilization, and then summarize this with some opportunities that might be interesting to many of the people on the call. So let's start a little bit with the ancient Greeks. Prometheus is a titan, and according to Greek mythology, the god of fire was punished by Zeus because he shared his knowledge of how to make fire with mankind, for which we're very grateful. And as a punishment, he was chained to a rock in the Caucasus Mountain. And every day an eagle came and ate part of his liver. And during each night, the liver would regrow, which meant that he had to endure this punishment for eternity. This is interesting for a bunch of reasons, because the Greeks describe here the ability of the liver to regenerate, which was a suggestion that ended up being proven to be true over the last 100 years. And the liver is the only solid organ that actually has that ability to regenerate. So for those of you who are not familiar with the liver anatomy, the liver sits very central and feeds into the heart. All the blood from the gut, from the nutrition, goes through the liver and then back to the heart. This is a healthy liver that's soft and glistening. Actually, when you touch it, as a surgeon, we get to do that. It's somewhat slippery. It's fairly large. It's 3 to 5 pounds, and it has a lot of functions. Among this, I always tell students the liver is a protein factory, right? It creates proteins. Proteins are important for clotting factors in order for us to fight infections with IgGs, for oncotic pressure with albumin. It's also responsible for detoxification. So everything we put in the gut goes through the flow through the portal vein, through the liver, and then back to the heart. So it's responsible for detoxifying drugs and alcohol and environmental toxins that pass our body. It's also responsible for glucose balance, bile production, for wastage. It's actually responsible for coloring our stool, for cholesterol production, storage of micronutrients, metabolism. So the liver has a broad array of really important functions. We cannot live without a liver. So common reasons why the liver might get diseased are viruses or a poor diet, growing obesity with the obesity endemic, excessive alcohol use disorder, street drugs, toxins, autoimmune diseases, and genetics. When these toxins are exposed to the liver over an extensive period of time, this soft and glistening organ can go from a healthy liver to changing over time, getting partially scarred, and then ultimately turning into what is hard and scarred and nodular and shrunken. This is the kind of liver, as transplant surgeons, that we remove out of the body. Well, here just a little bit of histology. I'm not going to go into this very deeply, but what you'll see on the left side is the perfect anatomical structure under the microscope of the liver. And what you see here in red are the liver cells, and you see this kind of structure that actually is in beautiful channels, brings the blood flow to and from the liver. And what you see when the liver goes through these stages and turns cirrhotic, this anatomical structure is destroyed. You see a lot of this blue, which is basically a scar tissue. You see that this lovely structure here is completely destroyed. Well, in terms of when we talk about cirrhosis, we usually talk about, as clinicians, compensated and decompensated cirrhosis. So a lot of people who actually have cirrhosis, they don't even know it. They might be asymptomatic. They might have some fatigue, but we all have some fatigue, right? Some of them might have some itching that often brings them to the doctor, or covert hepatic encephalopathy, which is just a fancy name for saying forgetfulness. Again, we often might find reasons why that is normal. But these patients who have cirrhosis, those who know it and those who don't, they're at significant risk to develop liver cancer. And that is not unusual. Every scarred organ in our body obviously is at higher risk for cancer, same for kidney failure or for burn injuries. So what happens when the liver, which is so central to what we do, turns into this rock and prevents the smooth flow through the portal vein back into the heart? Well, the heart is where we have the lowest pressure in the body. And so it's like water flows downhill. Blood always will flow to the liver. So it finds different ways of doing this, and to the exclusion of the liver, which has so many functions. So that has a lot of effects. Less blood goes through the liver, finds different ways of going back to the heart. That means there is less nutrition going to the liver. There's less protein production. That means less clotting factors. That means more bleeding. That means less immune globulins, which means more infection. That means less albumin. That can lead to a reduced oncotic pressure and to what we call ascites, where the belly gets really big, to muscle wasting. The body's very smart. So if it needs more protein, it takes it from where it can get it. That might be the muscle, but then you have muscle wasting, right? And we mentioned there's detoxification that the liver is responsible for. Well, now instead of getting flushed through the liver and excreted, that goes directly to the brain, and it can make us foggy and confused, very frustrating for patients. It can affect the glucose storage. Once the liver is not able to store glucose, that's really at a very terminal stage. But also it can mean that the bile that it produces and excretes into the gut is less effective. It means people get yellow, they retain that color from the bile. It can affect other organs. So when the liver fails, it also affects our kidneys. And as I mentioned, it finds different ways of going back to the heart, right? What's close here is the stomach, it's the spleen. So it uses these little capillaries to go back to the heart, and that leads to what we call varices, and can lead to gastrointestinal bleeding, can also lead to more sequestration in the spleen and to low platelets, which again leads to more bleeding. So the consequences of portal hypertension and decompensation are very significant. So when you kind of look at cirrhosis and the landscape of decompensated versus compensated cirrhosis, here in this graph, you see that patients with compensated cirrhosis, they live longer than patients with decompensated cirrhosis. The transition from one state to another is about 5 to 7% per year, with a median survival with compensated cirrhosis of about 12 years. That drops to less than 2, actually about 1.8 years. Those are data from a very renowned researcher, D'Amico, who is from Italy, and he's published these data on a cohort of patients from the 1980s. I'm pointing this out because I'm going to get back to this later on in this talk. So once the patient has decompensated cirrhosis, it becomes more of a systemic disease with a multi-organ failure. Now, patients with decompensated cirrhosis become highly susceptible to bacterial infections because it affects the innate immunity. So there are some challenges when we want to learn more about cirrhosis. Clearly, this is a morbid disease. I'm going to go into how many people are affected by this, but there are challenges to study this, right? With end-stage renal disease, we have USRDS data that captures everybody who's on dialysis. With transplant patients who make up less than 1% of patients with cirrhosis, we have a national data registry called UNOS that captures everybody with cirrhosis who's listed for transplant. But we don't really have good cohort data on patients with cirrhosis. Also, you look at the inpatient sample, then you don't have longitudinal data. So we actually are very lucky here because we have access to some of the data sources that allow us to do population-based analyses. One of those data sets, based on which we've published a lot of the data that I'm going to be presenting, is HealthLink. Abel Coe, who you all I'm sure know, created this data registry directly from EHR, so electronic health record, at the time from 6 healthcare systems between 2006 and 2012. Since then, this has merged into 9 healthcare systems that capture data from 2011 to present, and is funded by PCORI, the Patient-Centered Outcomes Research Institute. We also have access with Ron Ackerman to administrative data, United Health Group data that reports on data between 2011 to present. Those are insured data across the country that are representative of insured Americans. So if you want to really study cirrhosis, you've got to at this point, mix and match a little bit to find cohorts that are as representative as possible to answer more questions about it. So we looked at this in terms of the prevalence. You would think that's an easy question, right? And we hear a lot about NASH cirrhosis. Dr. Lisa Van Wagner gave a fantastic talk a few weeks ago about that's related also to NASH cirrhosis. And we know that's increasing with the increased epidemiology, pandemic basically, or epidemic of obesity that's related. But what about cirrhosis overall? And what we found was that when we looked at administrative data of almost 400,000 patients, that first of all, there's a significant increase over the last 6 years. In fact, about a 2-time increase. When you look at general data, when you kind of look at the literature, it ranges from 0.27% from certain cohorts to 4.5% when they looked at random biopsies. So it is probably more closer to 4.5%, but we don't know the answer exactly, right? So we looked at this large data set. I'm going to just give you a little bit of an overview what compensated versus decompensated patients look like. In terms of cirrhosis, most of them are in their 60s. There's less women than men affected. The etiologies are usually alcohol use disorder, NASH, which is related to obesity, diabetes, and hypertension, hepatitis C. In this data set, we actually have really nice longitudinal follow-up over 700 days. And I'm going to get back to the MEL score in a little bit, but I just want to point out that it's actually fairly low, between 10 and 14. When you look at cirrhosis kind of over the age distribution, again, you see more men than women affected, but it's really something that increases with age. So you see the peak around 60 or even later, and it stays on until patients are over 80. When you look at this distribution by the most frequent etiologies, which here also includes biliary cirrhosis, again, that distribution is not very different across these etiologies. When we looked at this over time between 2012 and 2018, what we found was what has been previously well described is the significant increase in NASH cirrhosis. But what we also found is there's increase along patients with alcohol use disorder, there's increase along those with hepatitis C. Now, around this time, a medication became available that actually treats hepatitis C very effectively. That wasn't really available before. And so you see this leveling out, and we expect that to actually reduce over the next 10 years. Biliary cirrhosis is increasing at a slightly lower pace. What was interesting when we looked at this is actually, so there's increase everywhere, but those with Medicare Advantage insurance versus commercial insurance had not only a greater incline, but also overall were affected more, which again makes sense to some degree, right? Because we just saw that cirrhosis affects more patients who are older, and Medicare Advantage would be patients who have Medicare plus commercial insurance, which is available for patients over 65 in general. So one of the things that we always want to know is what's the mortality rate and related to cirrhosis. And a lot of work has been done. In fact, about 70 years ago, two very smart people, Dr. Childs and Turcotte, came up with a system that allowed us to look at mortality using some clinical parameters, ascites, hepatic encephalopathy, nutritional status. And then about 20 years later, Dr. Pugh added a clotting factor. And that was kind of how we looked at mortality prediction for patients with cirrhosis for a very long time. The problem is we use those parameters also to identify who should get a transplant, and in the United States, the sickest receive a transplant first. And you can tell these are parameters that are somewhat subjective. What is moderate? What is severe ascites? And so this was replaced by the adoption of the MELD score. And the MELD score is dependent on 3 lab parameters. One that measures clotting ability, one that measures kidney function, because as I told you before, the liver actually affects the kidney. One that measures the bilirubin. So if it accumulates in the body, this level goes up. And that was used for quite significant time. And then and about 5 years ago, it was identified that really if you add sodium, because it also affects electrolyte balance, if you add that, it's a better predictor for mortality. And if you look at the MELD distribution here by age and by MELD score, it's really the same, no matter if your MELD score is high or low. And for those of you who don't know the MELD score, 6 is the lowest score. 40 is the highest score, and it's a 3-month mortality predictor. And someone who has a MELD score of 40 has an 80% likelihood of dying within 3 months. Someone who has a MELD score of 6, which I hope is everybody here on the call, has a 3-month mortality or even 1-year mortality that is way less than 1%. So the score is kind of is a mortality prediction, and on that score you have more access to transplant if your score is 15 or higher. And here's just a diagram that demonstrates, well, that makes sense, right? You have those patients who have a MELD score over 15. So again, 40 is the highest. So these patients, they have a higher likelihood of dying versus those that have a MELD score of 15 or lower. The problem is, though, and that's the key here, the majority of patients with cirrhosis have a low MELD score. The MELD score is a terrific score for organ allocation. Organ allocation affects less than 1% of patients with cirrhosis. If we just look at the wait list, most of them have MELDs less than 18, or another study shows 73% have a MELD score of less than 16. And transplant is geared towards transplanting those with a MELD above 15. But if you look at this diagram here, is most of the patients are here, below 20, below 15. And if you look at those with decompensated cirrhosis, so those that have quite significant symptoms, most of them, again, are here in the lower part of this diagram. And the MELD score is a fantastic predictor of mortality for high MELD scores, which is entirely appropriate for organ allocation, but it is not very predictive of those with low scores. In fact, it has an AOC of about 0.6, which is a little better than a coin toss. So if we look at those patients with low MELD score versus the high MELD score, what you'll see again is on the low MELD score side, you have more women, you have less patients with alcohol use disorder, and here, importantly, less people listed for transplant and even far less people receiving a transplant. But amongst those with low MELDs, there's still a lot of patients, overall more patients with high risk factors for mortality. So you might be like, well, they might die, but they might be dying from something completely else. So we used the HealthLink data we had and we merged it with the Illinois Department of Public Health Death Registry, where there's information about cause of death, and also with the transplant database UNOS. And one of our postdocs, Dr. Mazunder, did a fantastic job reviewing over 2,000 death certificates and categorizing them. And myself and one of my colleagues, Dr. Levitsky, reviewed these with him and categorized them. And what we found was really interesting. So as you would expect, the mortality is pretty high for those with a MEL score above 15, but the rate of death amongst those with low MEL scores was still pretty high. And most importantly, almost 50% of patients who die, who have a low MEL score, they die from cirrhosis. They might not even know they have cirrhosis, but their cause of death is related to their underlying disease. I think this is a really important point here because it means we need to pay attention to these patients. We looked at disparity amongst patients with cirrhosis, and we found some sex differences. We know from other studies, sex differences contribute to outcomes in patients with chronic liver disease, yet less women have cirrhosis. And so again, we looked at our data and we saw, well, liver-related death in women is no different from men, but non-liver-related death in women is lower than in men. That is widely known. Interestingly, women, despite having the same liver-related death, have a much lower wait list, are much less likely to be waitlisted for transplant, and are much less likely to get transplanted. That's an opportunity for improvement. We looked at racial disparities and found that Black patients had a higher all-cause mortality when they had cirrhosis, but we also found that they had a higher liver-related mortality. So the mortality in Black patients in the greater metropolitan Chicago area was 27% higher, but the rate of transplant was significantly lower. Speaking of a disparity that needs to be addressed. In fact, one of my partners, Danae Simpson, is actually addressing this through the ATAP program, the African American Transplant Access Program, which is a fantastic opportunity to try and mitigate such a disparity. There's a lot of research here that can be done. So the known drivers of mortality are infection. And when I talk to our students and fellows, I ask them, what do patients die from before transplant? Infection, infection, infection. What do they die from after transplant? Infection, infection, infection. It really drives mortality. It's a tremendous risk for our patients. In fact, it's fourfold increased in some of the data, a 63% one-year mortality after a significant infection. And although that has improved in a data set before 2000 and after 2000, it's still very high. We looked at data recently of this 600 patients hospitalized at NM. 40% were women, average age was about 58, MEL score around 28. These are patients who are in the ICU. Almost 60% had infections. The multi-drug resistant colonization was about a third, and multi-drug resistant infection was about 12%. So what we concluded from our data was colonization and infection with multi-drug resistant microorganism was associated with lower patient survival, patients with cirrhosis, that is. And the adjusted odds ratio was 0.6 and 0.2. This is a great opportunity to improve care. What are other drivers of mortality? Portal hypertension, as I mentioned before on the diagram, renal dysfunction. We know from other chronic care situations that mortality increases with increased renal dysfunction, and that has also shown to be true in patients with cirrhosis. Cardiac comorbidities, this is a field that Dr. Van Wagner really leads nationally. End-stage liver disease patients have a high cardiac output with low systemic vascular resistance and a hyperdynamic physiology. They have increased coronary artery disease, especially with the growing NASH cirrhosis population. Here's a study of one of our postdocs, Kofi Atiemo. He looked at other drivers of mortality, specifically in low MELD patients, and found that severely low albumin was significantly associated with higher mortality. Also, moderately low albumin was associated. And then again, parameters we kind of knew about: hepatic hydrothorax, ascites, malnutrition, very much associated with higher mortality. So as a clinician, we got to be aware of patients with low MELD but low albumin. These patients are at risk. So one of our pursuits has been to really figure out prediction. When you see a patient, you want to know, so how significant is the risk of their mortality? And this actually has been done before, as I mentioned, to bring you back to this highlighted paper by Dr. D'Amico. And these data are terrific, but they're really old. And they're from an Italian cohort from the 1980s. Now, that's a very different population than we have 40 years later in the United States. And other publications have come out that, again, are really prior to the epidemic of obesity that we're facing, prior to the treatments for hepatitis C. And so cirrhosis, the whole makeup of cirrhosis is changing. And so there's a lot of new opportunities that we're pursuing right now with newer data sources, more sophisticated methodology to have better prediction of mortality for those patients with cirrhosis. What about the less tangible drivers of cirrhosis? Health literacy. Many of you probably know that the average health literacy level in the United States is a 6th grade reading level. Most of us here on the call have been in school for over 20 years. That is not the truth for most Americans. Now, when you have chronic diseases, that reading rate level is even lower. And we had gotten some funding to do a public survey on patients nationally with cirrhosis. And the survey was actually more about what is it that you really would like to know more about? And the results were very surprising. Because what they said was, we want to have better information on cirrhosis, on the disease itself, which was baffling to me because I thought, well, there's so much information about it to explain what it is. And they were saying, well, it is too complicated. And so I had a summer student do a review of the top 20 general health platforms. So, and you Google, and top 20 high volume hepatology transplant centers in the country. And look at this for readability. So there are different tools available. Flash Kincaid grade is probably what most of you are familiar with. Word counts. When you're confused, when you're chronically ill, you don't have the endurance to read for half an hour to get to the point. And what we found was rather baffling. So the average reading level on that basic information about cirrhosis was 12th grade. Medline did best, that's almost 7th grade, but as I told you, the average reading level is about 6th grade and probably lower because these patients have chronic diseases, and that was no better for clinical hepatology websites. So there is a lot of opportunity here to improve on patient education. Frailty and sarcopenia, also less tangible driver of mortality, but a lot of work has been done in this area lately. It's a biological syndrome of increased vulnerability to health stressors, right? And actually, one of our colleagues at UCSF developed the liver frailty index that clearly showed those with higher frailty levels are more likely to die on the wait list, but are also more likely to die after transplantation. So one of our students in Yolson looked at sarcopenia in our patients. Sarcopenia measures the psoas, and all our patients who are waitlisted, they have a lot of a lot of imaging, and she looked at almost 400 patients after transplant and associated sarcopenia with clinical outcomes. And what she found was these patients, if they had higher sarcopenia, they had longer lengths of stay, higher admission rates over 6 months, higher mortality. So this is an opportunity to improve frailty. We know increased frailty leads to mortality for patients with cirrhosis, for patients after transplant. So this is great. And actually, there's been some studies that show this is not great. This is a great opportunity for improvement. However, studies have shown that with a personal trainer, with physical therapy, frailty can be improved, but that's really expensive. For those of you on the call who are clinicians, you probably are aware it's really, really hard to get physical therapy, especially intensive physical therapy for your patients. So the way to do this is to help patients do this themselves. And most patients, again, they don't have the resources to go to a gym. They don't have the resources to buy expensive equipment. So one of our postdocs, Avesh Tulavath, designed a frailty intervention called LIFT that doesn't require expensive tools. In fact, it requires these things we can actually buy for our patients, some dumbbells, some exercise bands, and feedback through an app, and he will give feedback to these patients on a weekly basis, and then together with a physical therapist would help them kind of get stronger between their regular clinic visits. And so far, this is an ongoing study. It's over 80 patients enrolled, but the adherence to their protocol is about 60%, which is acceptable. And those who have adhered to the protocol in 80% showed improvements. So hopefully in a few months, we'd be able to show you some more of these results, but this is a great opportunity for patients to kind of improve at home. Personality, right? And a lot of people talk about personality in many settings, and that has never been looked at in cirrhosis patients. And we know from other studies that personality traits influence clinical outcomes, especially in chronic diseases. And so the big five are conscientiousness, extroversion, openness, neuroticism, agreeableness. And so we looked at this for cirrhotic patients. Together with Dr. Morchak, we designed this hypothetical mechanism why personality might matter as we take care of patients with cirrhosis. It was interesting. So we looked at about 260 patients. And when you look at these numbers, cirrhosis versus the general population, that doesn't seem much, 2.9 to 2.6 in terms of clinical differences. This is actually significant. This is something that is noticeable. So amongst those patients who are listed for transplant, our patients have more agency, agreeableness, extroversion, neuroticism, and openness, but they have less conscientiousness, which was an interesting finding because we also found that those patients who are above the mean versus below the mean in terms of conscientiousness are more likely to get transplanted. Why that is, that requires some further investigation and maybe is an opportunity for personality-driven support for our patients. What about cognitive impairment? We know that cognitively about 80% of patients are impaired, although they might not have overt hepatic encephalopathy. And so together with Dr. Kim, we looked at certain measures to look at cognition, the NIH toolbox, and looked at this in almost 130 patients and saw clearly that cognitive impairment was associated with not just increased risk of overt hepatic encephalopathy, so not just kind of subtle confusion, but now it's really overt, but also with death. This is interesting because there are probably easier ways to get at that, to get at early dysfunction. And our fellow is looking at this using PROMIS measures. So PROMIS measures, as you know, in Dave Sella's group, are tools that we can use without spending a lot of time. So there might be a bank of 40 questions, but the patient only has to be asked 4 questions to kind of get a pretty good assessment. And what was found is that the PROMIS scores, first of all, the physical PROMIS scores significantly correlated with the liver function tests. They also significantly predicted hospitalization rates. For care, that might be really interesting. Similarly, with the PROMIS cognitive function, where the PROMIS scores significantly correlated with the short-term memory, especially in patients who had not been diagnosed with HE. It also was correlated with higher hospitalization rates. And so this might be an opportunity to integrate this more into our daily care. Cirrhosis leads to significant resource utilization. Here's some preliminary data. This is something we want to dig deeper into. Hospitalization rates are known to be increased in patients with cirrhosis, but how much has not really been described. When they're hospitalized, they're usually hospitalized for longer, and it's more expensive for the days that they're spending there. And if you compare this amongst patients with cirrhosis, you have a general hospitalization rate in the general US population of about 7.4%, whereas all patients with cirrhosis, we're talking close to 30%. Now, what's interesting is, remember, those who are compensated are the majority of patients, many of which might not even really be aware that they have cirrhosis. Their hospitalization rate is over 20% per year. This is also important because it costs a lot of money. Cost data are a little bit older, but in 2015, hospitalizations alone were at 16 billion attributed to cirrhosis. As I mentioned, hospitalization costs, once you are hospitalized, are significantly higher. The costs have tripled between 2005 to 2015. These are investigations that are, we're trying to figure out what it is now in 2022. So in terms of just giving you a quick summary of all the things I quickly ran through here, one of the problems is that we're underestimating the population that actually has cirrhosis. And there are studies ongoing. Dr. Ciolino and myself lead the SDCC for the Liver Cirrhosis Network, which is an NIDDK sponsored network that will look at this across 10 centers. It will be a fantastic opportunity over the next 5 years, the knowledge that will be gleaned from this. But we need other cohorts. We need to get more representative population-based cohorts to really study and understand patients with cirrhosis. These patients are particularly a good target for guideline adherent care. We know with guideline adherent care, there's less progression. These cancers I mentioned at the beginning of the talk can get earlier treatments. One of those treatments might be liver-directed therapy or surgery or transplantation. But I told you, transplant is only available really for those with high MELD, but there's living donor liver transplantation for everybody can identify a donor, and the liver regenerates. So everybody can be a donor theoretically if the liver can be divided into 2 equally working parts. Sometimes that's anatomically a little bit challenging, but the liver will grow back both in the donor and the recipient. So it's a huge opportunity for living donor liver transplantation. And patients who receive a living donor liver transplant, they do way better than those who are waiting for transplant. Also, patients who receive a deceased donor liver transplant do better than those who are just waiting. There's clearly an underestimation of the mortality prediction. We know some of these causes that we discussed are a decompensating event, but others are low albumin, malnutrition, frailty, sarcopenia, renal dysfunction. But there's a lot of opportunity for refined prediction, refined predictive models, for care prioritization, but also there's opportunity for biomarker investigation. There's disparity that needs to be targeted. There's lack of access for readable educational material for the patient population itself. So there's educational opportunity. We don't really know much about personality traits, so more investigation is required. Early interventions might be appropriate for cognitive impairment and hospitalizations. Care pathways, we have a large Northwestern system that can be leveraged. Rehabilitation for patients with frailty and sarcopenia. This was a brief overview over a lot of investigations that we do. I'm sure there's many that I have forgotten here, and it is by mistake, but I want to point out the tremendous work, especially done by our postdoctoral fellows, by our predoctoral fellows, and our staff. This kind of work cannot be done without significant boots on the ground, and we're extraordinarily lucky. As Tara mentioned at the beginning, this is really truly the result of transdisciplinary work. Most of the people you see here are not transplant surgeons. They come from very, very different fields, from different schools within Northwestern. And that has made this a really fun run. And so I'm very appreciative of all these colleagues. So thank you very much for your attention.
Thanks so much, Daniela. That was a really comprehensive and whirlwind talk. We really enjoyed it. I'm going to start with a question from Jenny Ding, who asked, are there biomarkers that can suggest disease onset, and is there a role for early detection of cirrhosis?
Yeah, these are great questions. So in the biomarker is a loose term, right? So there are some ways, just labs, when we draw blood labs, we can sometimes identify when there's liver disease. But biomarkers, as we understand it, kind of now in terms of early signatures in the blood, that is something that's really just evolving. There are investigations in terms of microbiome, in terms of examining stool samples. That's actually really big now, but very much kind of in the early stages. There's no blood biomarker that has been identified to identify not just those with cirrhosis, because that's actually easier to do, right? You can take an ultrasound, you can take a fiber scan, and you can identify patients who have cirrhosis or do a biopsy. But it's which of these patients will be decompensating and will be at greatest risk for having a poor outcome. And no such biomarkers have been developed, but there's a lot of interest and a lot of investigations going on.
And then, if you could detect cirrhosis early, how would it change your management, or what would you try to do differently in the clinical setting?
I mean, cirrhosis can be detected if you look for it, right? If you were to just focus on those who actually know they have cirrhosis, so someone actually diagnosed it, there is a lot of intervention you can do. Only 30% or less get guideline adherent care of those who have cirrhosis where it's been diagnosed. I think that's probably the first step to try and get to those that have been appropriately diagnosed and provide them with the best care possible, and also identify those amongst all those, because those that have been diagnosed, probably we're talking over 10 million people in the United States, right? So to provide them with the most appropriate care. And, you know, guideline adherent care would mean they see a gastroenterologist or hepatologist once a year, they get biannual cancer screening. Biannual cancer screening is actually fairly simple to do. You just have to have a process that automates that. And that's where often things fall short. In terms of investigation, kind of knowing which of these patients up front, knowing which of these patients are at great risk, that's where a lot of the investigation is ongoing. Once you have decompensating complications, we know more. But just amongst the big mass of patients with cirrhosis, which do you have to pick out to really pay attention? Because in fact, we don't have enough resources for everybody to be seen by hepatologists or gastroenterologists. There's simply not enough caregivers out there. Now, the question actually was like, how do you improve the diagnosis of cirrhosis? So as I mentioned, we have pretty good tools to actually diagnose this if we look for it. The problem is more, is it actually being looked for? And so that's more kind of would require really focusing on primary care physicians to be able to diagnose this earlier. But I think the real opportunity is once it's diagnosed.
Great. Maria Bukowska says, is there a level of alcohol consumption that does not increase risk of cirrhosis?
Yeah, 0. That's, you know, there's a body of literature out there to kind of try and approximate what is tolerable. The truth of the matter is the enzymes that process that alcohol are kind of different. They're dependent on weight. So men in general are their mean weight is higher than, or their median weight is higher than women. And so in general, you can say they can tolerate more alcohol, but it's very individual, right? Some people don't have the same amount of enzyme or don't have it at all. So there is no back of the envelope suggestion how much you may drink. What we do know is if it's really frequent, there's this continuous injury and the liver doesn't have time to regenerate. So drinking occasionally a lot versus every day is better, but that's in no way or form an endorsement for drinking. The way to prevent alcoholic cirrhosis is not to drink.
I think you might have said some of this, but we have a question from Cesar Escareno. How predictive are race and gender of cirrhosis progression and outcome?
Hi, Cesar. He was one of our fellows. So how predictive are race and gender of the progression was the question. Well, in terms of the progression, we don't know much independent of race and gender. There's a lot of investigation to be really understanding which patients progress. In fact, a lot of the focus of our R01 work is trying to identify those patients who will progress. And so hopefully those are answers I'll be able to give in a couple of years.
Well, and actually that's a question that I kind of came up with as you were talking. What really feels like is that you have so many potential next steps. I mean, you've got strategies for addressing frailty. You've got the idea about mortality prediction. You want to really describe the natural history of the disease, which hasn't been well described. So I guess for this group, what are your obvious next steps that are immediate? And what would you say is the most urgent of these to improve care for people with cirrhosis?
I'll preface this with, this is my personal opinion. I think we have great opportunities with our electronic health records to really implement the knowledge we have gained. So one of the things we know is if you check for cancers, for liver cancers, twice a year, you're more likely to identify it early, and it leads to greater survival. These patients can be treated with liver-directed therapy, surgery, transplant, and we don't take advantage of this to the extent that I think we should. To me, the most exciting next step is actually to create a cirrhosis pathway. A system like Northwestern has information on thousands of patients. In fact, I know we have 20,000 patients with cirrhosis in the system. It's easily to identify. I also know only 4,000 of these patients are actually seen by gastroenterologists or hepatologists. We also know that about 6,000 patients are have not received their cancer screening in the last year. So there's this tremendous opportunity to take what we've discovered in research that is established and actually implementing it into care, such that when a patient comes and passes the threshold of Northwestern, they will get the optimal care. I think as a clinician scientist, to me, that is the most exciting, because that's where I see all the research and all these publications and all that work actually directly affecting patients. From an investigative perspective, I'm really, I think our R01s, they focus really on risk prediction to identify those that should be targeted. To me, that's really interesting because they're emerging therapies. LCN is actually looking at statin as a potential drug to reduce progression. There's going to be more and more emerging therapies, and you got to know who is at highest risk for treatment. With limited resources, you also got to know who really needs to see a specialist and who does not. And so to me, that's really the exciting part, looking at this. And then also from a public health perspective and public policy perspective, to know what the exact cost is. I firmly, again, this is a hypothesis that I believe in, that if we were far more proactive, that the cost these patients generate would be significantly lower, which from a public health policy perspective is interesting. And if you can really demonstrate with dollars that it is far cheaper to find them, to target them, and to treat them, that you don't spend all that money that's coming down the line. So even if you look at it, not from a physician perspective, but purely from an economic perspective, that doing the right thing early on is going to be really the right thing to do. And this is a huge and growing population. And so these are kind of the things that I find most exciting.
Great, thank you. We have a bunch of great questions in the chat, and I really think we only have time for one more. Dr. Hassan Alam says, excellent talk. The impact of alcohol on society is probably larger than tobacco. Auto accidents, crime, cirrhosis. Should it be a target of political and legal reform similar to smoking and tobacco?
That's a excellent question, and comes at it a little different actually than I have thought about it. You know, as a transplant clinician, I feel there is so much judgment towards alcohol use disorder. I, in the literature, see alcohol use disorder as a disease, much like diabetes, but there's not that whole societal judgment that comes with diabetes, whereas with alcohol use disorder, it does. And so I see that as really an important step to look at it and treat it like a chronic disease, which involves recurrences, relapses. That's part of the disease, and really figuring out the best way to support these patients. In terms of, from a public health perspective, I mean, Other countries have tried and have made alcohol illegal, and we in our history have made it illegal at some point. And the truth of the matter, these have not been very successful interventions. It just creates a huge black market. It doesn't really reduce alcohol consumption. It changes the demographic of who drinks, but doesn't really change the problem. And so I believe, and I'm not an alcohol use disorder expert, but I believe really working on the perception of alcohol use disorder is going to be where we can have the greatest impact. And also as clinicians, that we really get to a point where we regard it as the chronic disease that it is, and not as something that people do to themselves.
Great. Thank you so much for joining today. There were some questions we didn't get to, but otherwise it was a really great talk, and we really appreciate having you.
Thank you for having me. Have a nice day. Bye-bye.